Hi, everyone. We will begin the office hours very shortly.
Good morning, good afternoon, everybody. Just going to give folks a few more, not too many few minutes, but a minute or two to join in. While we're waiting, a fun fact that I learned the other day is Leah and Helen and myself are August babies. So they're my August buddies. Anyone else tuning in as an August baby, let us know. Join the club.
Virgos out there.
How we're looking.
Pretty good. All
Yeah.
right. So good afternoon, everyone. Thank you for joining us today for Office Hours with Dr. Chi. My name is Helen, and I'm with the Glidewell.io marketing team. And joining me here today is Leah and Dr. Justin Chi. So a couple things before we get started. This session will be recorded, and it will be available to you on demand. At any time during the presentation, please type your questions in the Q&A box, and we'll address it at the end. And lastly, on my end, just a quick little intro of Dr. Chi. He is the Director of Clinical Technology at Glidewell, and he leads a few of the Glidewell.io advanced trainings here at our campus in Irvine. So if you haven't visited us yet, we would love to welcome you to our campus and spend a couple days learning in person with Dr. Chi and other Glidewell doctors. And with that, I'll turn it over to you, Dr. Chi.
Thank you, Helen, and good afternoon, good morning, wherever you're at. Thanks for joining us for today's office hours. And what we're going to highlight today will be our latest offering, Bruxer Now Screw Retain Crowns. And we're going to review the workflow, what is it, what it entails, and focus on the design component. So let's see here. So this is a good look at the block. So the dimensions of the block are going to be very similar to your standard posterior Bruxer Now crown block. The main difference, as you can see in the center, there is the screw access channel, as well as on the gingival side, you will have a tie base. And so some of the details of this block, it is the fully centered Bruxer Now full strength formulation that you currently enjoy in the Bruxer Now material. And the tie base, what makes this unique is the tie base has already been pre-cemented, pre-bonded to the block. And once you scan the scan body, design and mill this out, just like the other Bruxer Now materials, it's kind of like mill to mouth. So that's sticking to the concept of what we would like to achieve with the system simplicity. What you get with the block, each block will come with a single-use diamond burr as the other crown tooth-borne Bruxer material, and it will also come with the abutment screw. Pricing for the block, it will be $169, or if you are a gold member, it will be $139. Compatibility. So the key focus of the system during this initial launch will be for the Glidewell HT, formerly Han tapered implant, as well as the Glidewell Inclusive. The Glidewell HT implant is a conical connection, and the Glidewell Inclusive is a hex conical connection. So it's kind of like a hybrid connection. And They are there are compatible systems that match the same connection and certain sizes of the HT and the inclusive. So far, we have identified these systems, and I do want to preface as you are reviewing, if you are a user or restoring dentists of these other systems, I do want to still caution you before you acquire the blocks, and you would get the blocks through your client success manager or CSM. They can help cross-reference what system that you're looking into and make sure that the right size matches the same sizes that are currently offered for the Glidewell HT and the inclusive platform and size offerings. What we're actually doing is we are acquiring the implants of these known compatible systems, and we do just want to make sure that we do truly have the right connection and things are lining up the way that they need to. So we're going to gain a little bit more clarity as well as hopefully expanded systems. I mean, there's hundreds of systems on the market. We are looking into those with conical and the hex conical connection. We are looking to expand on the offering beyond just what is compatible with the HT and inclusive systems. We're looking first at the most used systems or most prescribed systems beyond the HT and inclusive that we see in the lab setting. So hopefully we'll have an expanded list very, very soon. Available shades. We are looking and we limited the offering to the shades that are most used for posterior bruxer restorations. So that includes the A1, A2, A3, A3.5, B1, C2, and D2. All right, so that is the block. Let's focus now on the site evaluation, some important aspects we want to consider before we go ahead and restore the site with this restoration. So one of the most important things we can do to establish a good emergence profile in our restoration is to possibly pre-contour the tissue. One of the best ways to do it is with a custom healing abutment. These can be offered if you are working through Glidewell. If you are placing implants yourself through our digital treatment planning department, you can have the custom abutment provided along with the guidance, the surgical plan, and obviously that creates the surgical guide. And so whenever the surgical guide is delivered, you will also have this custom healing abutment that sits level with the tissue. And what that allows for is it opens up the channel from the implant to the ridge level, and it can provide an improved tissue contour. And the improved tissue contour can lead to optimal material thickness and really just room for that final restoration. When we're designing screw retained crowns and implant restorations, one of the most challenging aspects is going from a real narrow implant platform to a natural contour in that restoration. So the more ideal we can create that transition from soft tissue, or rather implant to soft tissue to the oral cavity, the more ideal that restoration can be, and hopefully be strong and long lasting. The reason why these custom abutments is more favorable to, let's say, a stock healing abutment, the stock healing abutment tends to be really narrow in its profile, and that narrow channel that it creates can limit and constrict the amount of material we can provide and also limit that emergence profile, especially for deeper set implants. When the implant is set more apically, we have a longer distance that we have to travel from the implant to the ridge to the optimal occlusion in many cases. And that long distance of travel can create some irregularities or less than ideal conditions. So if we can make a wider base for the bottom of our implant, that gingival portion, it really helps optimize the strength and also the aesthetics. All right, so we have the emergence profile implant to the edentulous site. How about the distance from the implant to the opposing? Ideally, we want to establish at least 4 millimeters of interocclusal distance, or rather implant to opposing dentition. If we have less than that, it can be a really challenging situation, really challenging situation. So um, that constricts the amount of the components, because we have the tie base to the internal component within the block, and that, if we're less than 4 millimeters, it can interfere with the optimal strength and also the just general room and space to create a restoration. This is an example from my colleague Taylor Manalili, who restored this implant. The opposing tooth, as you can see, it super erupted into the edentulous site. And what she had to do was crown the opposing. So that looks like number 3 there. So by crowning the opposing, she was able to lower the occlusal level of the opposing tooth, number 3, to a more optimal level to create optimal space for the restoration. So very important consideration there. So we've got the opposing dentition we have to worry about. How about the adjacent teeth? So whenever you go to scan, hello, someone looks like someone logged in. Um, so
Hi,
once
Justin. Bye, Justin.
hi. So whenever you're evaluating the adjacent teeth, one of the best things to do once the scan body is in, because the scan body will identify the long axis and basically the insertion direction of the implant itself. That's the direction the crown will seat into the implant. And you can compare that long axis position of the scan body to the adjacent teeth. And ideally, we want to establish a similar insertion or contact angle as the implant itself. The more those deviate from one another, the more challenging the seating of the restoration will be. So this is a great example. This patient had 2 existing restorations next to the implant site. You can see how over-contoured right in the middle, especially that molar, the middle third of the mesial of that molar, the extension creates these black triangles. So the black triangles can also lead to food impaction. It can also lead to just the food impaction can lead to soft tissue inflammation. And as we know, inflammation is a real negative for the health of the periodontium and also that implant interface. So what we want to do, ideally, if we see this type of situation, and of course there's room, if it's on natural teeth, you have to consider the amount of tooth structure you are also removing from that tooth. But as you can see, if we can establish more parallel contact surfaces to the implant surface identified by the scan body, it's going to really improve on the delivery of that restoration. So once again, path of insertion is of vital importance. If you are placing implants yourself and you are doing them freehand, and if you yourself are seeing a big difference in the way that the implant body is positioned versus the long axis position of the adjacent teeth, really try and get that dialed in, or I would encourage you to perhaps try guided surgery. And that's one of the best things about guided implant placements is that it's a restorative driven implant position. And just sometimes whenever you're doing a freehand, it looks like you're lining things up appropriately. But depending on the angle, depending on the patient's position, it's real easy to deviate from your initially planned direction. And we see this all the time with implants being restored where the implant body and trajectory of that implant really does not align well with the adjacent teeth. And when that happens, screw retained crowns can be very problematic because the insertion direction for the implant is extremely fixed, and there's very little wiggle room for that implant to drop into position, the crown to drop into the implant. When the adjacent teeth are very different, the insertion direction or the contact angles of the adjacent teeth deviate quite severely from the implant position. So try your best. Again, if you are placing implants, you really want to try and get that implant in the right position. If it isn't, then a screw retained crown really is not the best option. The best option when the implant, and I understand it's real good, easy to say implants need to really follow the adjacent teeth. That's ideal, but depending on the bone levels and there are other factors, of course. But if the implant has to be off angle, then that's a situation where a custom abutment, maybe by a cementable or perhaps even a screw mentable restoration, is more favorable because you can, what the custom abutment's going to do is idealize the insertion direction for the restoration when the implant deviates from it. And by the way, I didn't mention the screw retained blocks can only currently be restored for posterior applications, so premolars and molars only. I'm sure there's a way you can trick the system if you tell the software you're doing another tooth. Let's say you're doing a canine and you set it up as a 12 or number 5. Of course, there's workarounds for that. Um, we're not going to stop you from doing that, but just know that the system itself, the design software, will only allow you to design if a posterior tooth number is set up or selected during the setup. So that's path of insertion. Now about the scans. So we essentially have your 3 scans, your virtual or digital triple tray. You have your arch scan where the implant is. Um, or excuse me, you have the arch scan, you have the scan body scan, and we're going to call the arch scan the opposing arch. You have your scan body scan where you have to identify the scan body and make sure that's scanned well with the adjacent teeth, and then your bite registration. So what this slide is trying to indicate is primarily for your bite scan, you may want to scan the bite with or really, I say you may want to, for your bite scans, because of the height of the scan body or the scanning abutment, the patient may not be able to bite fully with the scan body in. So when the bite is in, you may want to seat you don't have to, but if you have a healing abutment, you seat the healing abutment. If you're using a cover screw, or really nothing in there. Really, the objective is to not have the tall scan body in position where the patient could bite down on scan body and obviously record an inaccurate bite position. Or the arch scan of the opposing, as well as maybe the arch scan of the site, if you wanted to really try and capture maybe the contact surfaces of the adjacent teeth, that scan body, especially on a premolar, the scan body itself could interfere with the scanning of those contact surfaces. So you may also want to take the scan body out, capture the contacts, and then maybe put the scan body in to obviously identify that implant position, which the scan body is meant to do. Once you scan everything in, you want to be able to evaluate the quality of your scan. So just like with your tooth-borne preps, evaluating, you don't have margins here to look for, but what you really want to make sure of is the quality of the scan body is captured really, really well, the same as you would with a tooth-borne situation. So one of our favorite things to do is to change the scan from color to stone or the monochromatic view. Every scanner has this function. Whenever you change it to stone, oftentimes it will reveal the true quality of your scan. Sometimes the color can disguise whether or not there is an artifact or maybe a misalignment in the scan. What you're looking for is the complete geometry of the scan body, and also that the scan body is connected. A really important thing is that the scan body is connected to the ridge. So what we're seeing here, really on both of these scans, because both are done well, that the scan body looks as if it were in the mouth. You don't have any holes, you don't have any gaps, especially at the base of the scan body. Some scanners, with their AI cleanup process, it might eliminate part of the scan body when there are gaps and holes at that base of the scan body. So really make sure you get those right rotations, you're at the right distance, and see that the scan body is fully connected to the ridge. So once the scan bodies are scanned in well, as well as the adjacent teeth, as with any case, you want to make sure those contact areas are scanned in well. If the contacts are missing or, a little bumpy like this, it could lead to an inaccurate creation of that contact surface and lead to maybe a heavy or even worse, an open contact. So this is what I mean. If you were scanning the scan body in position, maybe it's a narrow site, you're unable to get those contact areas with, you try all these different angulations, maybe just the scan body is too close in proximity to the contact surfaces. You may want to remove the scan body and give a little bit more access for your the light source on the scanner to come into contact with those adjacent surfaces. The scan body, back to the scan body, again, making sure the scan body is scanned well. For the Bruxer screw retain block workflow, you have to use the Glidewell inclusive scan body. And so the inclusive scan body looks like, I know this is not the best example, but it's the on the bottom right here, but that's an example of a really poorly scanned version of the Glidewell scan bodies. You can see how bumpy, because the scan bodies are nice and smooth, you understand the geometry of that. If you see something like this, some distortion occurred, either maybe moving too quickly during the scan bodies have some contamination, saliva, blood, something on there. But this often does happen when maybe you're moving too quickly and the system was not able to stitch the data appropriately, or you're rotating too quickly. Something that you can do to improve on the scan. This is one of my critiques of the scan body. I wish the head of it, the top of the scan body were a little bit wider. And I wish the screw were level with that occlusal portion, because scanners have a tough time scanning real narrow areas on teeth, and of course with the scan body. But if your technique is done well, you go slowly and you're not moving too quickly, not too much coffee or caffeine running through your system where you're a little shaky, you should be able to get the scan body done well. And I'll show you my scan technique of the scan body. But if you see something like this, missing parts of your scan body, melted areas of the scan body, or bumps or lumps, it's probably best to just redo the scan, because yes, we're not scanning margins or axial surfaces of a tooth situation, but the quality of the scan body is going to be really important for the software to see where to position, to align with the scan body for the positioning of that design. So it's super important. If it's off in any way, that could lead to some inaccuracy on the way that crown is being designed, and you're going to have a tough time getting that to seat, if at all. So this is a good example. This is what we're looking for. Evaluate, of course, you can look at it in color, but one of the best things, change it to stone as we see, or monochromatic on the left. That's a high quality scan. The geometry, the surface texture, everything is nice and true to reality. And as I mentioned, one of the things that you can do if you're having trouble picking up the scan body is, of course, adjust the distance and the angulation, but you may also want to place a Teflon tape into there. If whatever you place in the screw access of the scan body to level that off, make sure it's not overflowing or kind of overlapping the top edge. So even, or if anything, just slightly below the top portion of that scan body. All right, so let's take a look at a case. This case here, this patient came in, as you can see, loss of tooth structure, endo-treated, some periapical radiolucency. So what we're going to do, the treatment plan is to extract the tooth. This isn't on implant placement, so we're just going to go through this. We place an immediate Han, or rather now it's the Glidewell HT. This is a 5 mm implant, all plan guided, so that the trajectory aligns with the adjacent teeth. With the immediate, we've got great primary stability, but obviously with the extra space, we're going to do this is our Newport Biologics cortical cancellous allograft. And what I ended up doing, we scanned the implant and at the day of surgery, and I made a custom healing abutment out of a Bruxer screw retain block. So I'll show you the design workflow for a normal crown. And essentially what I did was use the tools to drop this out of occlusion, really get it close to, and I probably could have gotten it even lower, but I basically used the tools for both freeform and the move, rotate, scale, and just drop the design down and really smooth that out. And it milled this out. And so this is seated into position over our membrane. And I was really just curious to see how will the tissue heal against this Bruxer material that wasn't even polished? And we know that Bruxer and soft tissue or zirconia soft tissue really creates really favorable conditions. So I was really just curious to see what would happen. So this is after 4 months of healing. That's ferment in the screw access channel to just seal that up. And this is what the after the healing with that screw retain block. Once we remove that screw retain, we're going to call it the custom abutment. There is, and this has been studied and identified, soft tissue does adhere to polished or unglazed zirconia, which this is. And so when I actually had to use quite a bit of force to take this off, and I mentioned Taylor. Taylor's like, this is why I really don't use zirconia healing abutments, and this is a really important note too. Why zirconia is typically not used for healing abutments because of this additional adhesion that is created with the soft tissue, and why zircon or titanium is typically used, real polished titanium. So adhesion forms between the zirconia and the soft tissue. So when we remove this, we can see some open capillaries. There may be a little bit of bleeding, which you may have to keep under control if you are scanning the site. So let's take a look at what we're doing. We're going to scan the site again post healing. So this is where I mentioned it probably could have brought it down a little bit more. But we're using our Medit i900 scanner. We're pre-scanning the implant arch. We always go, or typically always go from last tooth, and what I recommend last tooth to at least the canine. Here, our assistants, they like to get the full arch, but I'll tell you, it's really not necessary, especially if you're only doing a single unit side, because what that does, I find it delays, slows down the scanner. Obviously, takes a little bit more time for the scan itself, but that's okay. My assistants are really just used to doing full arch scans, especially from our initial evaluation, new patient exams. We always do full arch scans. So we removed the abutment. We have a real clear view. The soft tissue healed really nicely. There's a little bit of bony projection on the buccal. I inquired about that with a few other implant specialists, and they think, probably with a little bit more time, that'll continue to reduce in position. But we've placed the scanning abutment. So let's go back to the scanning abutment placement. Really important that it engages, it's down all the way. I really have a clear view because of the soft tissue opening. I have a real clear view of the connection to the implant, but always a good idea to take a radiographic image, PA or bite wing, to make sure that is sealed to the implant. We screw that down. And now we're going to take our scan. I like to take the scan of the scan body at a slight angle. See, I'm on the buccal here to capture the vertical nature or angle or surface of the scan body. And again, emphasizing the connection of the scan body to the ridge. So we had the entire arch scan before, and now we're just focused on the implant, or rather the scan body, which is identifying the implant position. So I'm really trying to make sure that it's well connected to the ridge. Because of the use of the custom abutment, I'm wanting to capture the soft tissue contour. So you don't want to delay the time between removal of the custom abutment and the scan, because the tissue will begin collapsing. You have a few minutes, but just something to be cognizant of. And also making sure that the contact surfaces are filled in pretty well. All right, so that is the scan of the arch. As I mentioned, for the bite scan, we did capture it freehand or beforehand, freehand. But if you are scanning the bite after, let's say the bite was coming a little bit later on some scanners, you may not capture it right away. Then remove the scan body, capture the bite. That allows the patient to bite fully down. So once we get into design, so this is now in fast design. When you open the case, or rather when you set up the case with the screw retain crown is going to be in a drop-down option. You set it up as a screw retain crown, making sure you select, and I'm sorry, I should have had a slide here, making sure you select the size of the implant, making sure the right system, number one, is selected, whether, let's say, for example, the Glidewell HT or inclusive. Then the right size, and on also the scan body size, it should automatically align, but just double check and verify that the implant size, diameter, scan body diameter is selected, and then also the shade. Then you advance the design. Now we are on the step right after you set up the case for an implant crown. If you have a great scan of the implant, this is what you hope to see on the next page. So this is replacing the margin page. So if you were, excuse me, if you were designing a tooth-borne crown, you would now be marking the margin. But with a screw retain crown workflow, what you're hoping to see when the implant scan body aligns and the software recognizes that position, you have a good scan, you will also see what you see below the model, and that is the implant analog. The analog is essentially a simulation of the implant itself. So that just means that is where the implant is on the patient. We identified where that is based on the scan, good quality scan of scan body, and we're good to go. I'm going to next review. Okay, so if you have the analog here, you're good to go to the next step. So there's really nothing else you have to do on this page. You're going to go ahead and click design on the bottom. What happens if you don't see the analog? If you have no analog, then the software is going to want you to figure out where this alignment of the scan body is. So we're going to do that by, on the left-hand column, we're going to click on this icon here. That is that implant alignment icon. When you open that or click that, you're going to see this window open. You're going to verify the implant system, the platform diameter, the scan body diameter, and also the block. It should all align together. So re-verify that you selected the right implant size. It could be due to the fact that you chose the wrong size. Depending on the diameter of the scan body may also be different. So once you confirm all of these options, if they're all correct, or even if they're not correct, make the correction. Then you're going to click on alignment of scan body. Once you click alignment of scan body, this is the next window that appears. You're going to see the scan body, the virtual scan body. I know there are two virtual scan bodies, but this is the scan body that we want, or the one on the buckle. This is the one we want to align to our scan. So this is when you kind of are confronted with whether or not the scan of your scan body was done well. If not, you're going to see maybe the lumpiness, maybe some parts of it missing. If that's the case, then hopefully there is what you're hoping for is there's enough of this upper portion of the scan body so that you can create an alignment. So something that you can try first. This is my order of operation. There is an auto button. Go ahead and try clicking auto. Click auto, give the software another chance to use what was scanned in. Does it identify enough information? If not, it will still be separated like this. The objective is to make these go together. If that doesn't work, you'll see above auto, there's two options, align type. I would recommend using by 1 point. So start with by 1 point. So when 1 point is selected, what that does is you're going to click 1 point on the scan body that you scanned in on the ridge, and you're going to click the same point on the scan body, this separate virtual scan body. So for example, I would click on one of these corners and then the exact same corner on the scan body over here. Pay attention to the geometry of the scan body. The scan body, the inclusive scan body, has two larger lobes and one smaller. So making sure that you are clicking on the correct area. But if the quality of the scan was not done very well, you may be better off just rescanning the situation. But try the alignment. Once you try the alignment, whether it's auto or the 1 point, what you're hoping to see is those connect together. What about the other line type? It's move, rotate. That's a manual movement. So if this is active instead of by 1 point, you're going to manually move, left click and hold and move that scan body to try and match and align as closely as you can. And then you'll apply it. To me, that's a little bit less accurate. You really have to get the angulation, the position of your model, and really move that scan body as close as possible. But from what I've seen, if you get a great scan of the scan body, that really is the most important thing. Okay, once the alignment is created, this is what you'll see. You'll just kind of see that separate scan body, the scan body that you scanned in, scan in well, and they're lined up nicely here. Okay, quick review of my design checklist, and we'll kind of reference this. I'll go back and forth. Form follows function, aesthetics follows form and function. So what we want is for the design to align well with the adjacent teeth and also good occlusion, good cusp-fossa relationship, depending on the occlusion. This patient has a little bit of funny bite, which I'll show you soon. It's more of an edge-to-edge bite, but ideally, if the patient, whatever occlusion the adjacent teeth are in, you're going to try and reestablish that into your screw retained crown. Aesthetic harmony, once it's aligned well with the adjacent teeth, we can look overall align well with the adjacent teeth. Then we can consider the true cusp height position. Does it fit into the adjacent cusp fossa relationship well? General position. Then we can consider the buccal corridor. Is it under contoured, over contoured, kind of established both on the buccal and the lingual contour, making sure that those are dialed in, close in size and shape to the adjacent teeth. If anything, depending on where you learn, there's different philosophies, schools of thought with this, as with anything in dentistry. Some really like to narrow that occlusal table, so you might really want to limit the amount of cantilevering both on the buccal and lingual sides. I'll show you my design approach. I like to get close in size to the natural contour, but something that I will adjust differently with screw retained crowns to tooth-borne crowns is I will make sure the cusp heights are going to be a little bit lower and a little bit less pointed because we want to limit the amount of lateral interferences on our screw retained crown, which could lead to failure of the components, loosening of the screws, and even worse, detrimental forces applied to the implant. So I will review that in design. Broad contact, good contact with the adjacent teeth in a height, buccal lingual width, occlusal gingival height, also general marginal ridge heights. I try to get those level with the adjacent teeth. If there's no occlusal interferences, good contacts with the adjacent teeth can also help provide stability for our implant. So adjacent teeth, when there are mesial and distal neighboring teeth, really help stabilize implant situations. It's the buccal and lingual areas that cantilevering or lateral forces can really potentially be detrimental. So that's why I mentioned the cusp heights. We want to keep those rather low. Rounded occlusal embrasures. So where those contacts are, just a little bit of an occlusal embrasure to help with food channel movement and also ability to pass floss through. Emergence profile, we've got a big area for emergence profile because, again, implant, narrow base, we've got a lot of restorative space. Good tissue contact is going to be nice to, especially with our the raw version of the zirconia. Soft tissue is going to help adhere much better. It can help limit bacterial infiltration or plaque from passing through that interface, minimizing food traps. With the adjacent contacts, if those contacts are not pre-adjusted, if there are large undercuts, try to avoid allowing the design to be designed into those undercuts of the adjacent teeth. Once the designs are done fairly well, then the final thing we're going to make sure, second to final thing, is going to be setting the occlusal and proximal contact values, which I'll review with you. And if you are using the auto fixed contacts in the contacts window, what can happen, you may have seen this even with tooth-borne restorations, is if there's too heavy of a contact or maybe the adjacent contacts surfaces are not ideally shaped or smooth, then you might create some weird distortion in the design. So really, anytime you use this, pay attention to what the software does because it may not always give you what you were planning for. So if it deviates or distorts the design, you may just undo it and then manually adjust the contacts. And I think in our example later, we're going to see that. So also the final thing, making sure the material thickness. You might be thinking, hey, there's no reduction in the prep. There's no prep. We're not working on tooth. There is what we have to be concerned with is the titanium abutment. So think about that as your prep. It's a real small titanium abutment on the inside of the Bruxer restoration inside of your design. The software will notify you if you are violating that material thickness. It's a real easy adjustment on the software. So I mentioned if the fixed contacts, if you did use fixed contacts and it does work well, it also actually adjusts any thin areas. But if the soft tissue is choppy, so if your soft tissue is not really contoured very well, let's say you took a burr or you lasered to try and pre-shape it, if it's actually bumpy, the fixed contacts will adapt to that bumpy surface. So what that could end up doing is distorting the contact surface, distorting that gingival emergence or gingival contact. So when you evaluate for distortions, don't just look at the proximal contacts, also look at the occlusion and the gingival area as well. But what I meant was if everything worked out fine, if using fixed contacts, the material thickness will also be taken care of. If using fixed contacts creates a distortion, then maybe you'll use the next to that button, there is also a protect thickness, which will only add to thin spots. So if you have any thin areas at the base of your restoration due to that proximity to the tie base or titanium abutment, it won't allow you to mill the restoration. So that is the design. Let's look at the design now. So this is that case, the number 30. We identified the implant. The software identified the implant. This is what we see when we first go into design. And I'm glad this happened. It actually didn't come out perfectly. Why it didn't come out perfectly, I'm not too clear on why, but we are working with the developers to improve on this. This isn't always the case, but why didn't it come out perfectly? So what's not perfect about it? So the first thing that I do see is the fact that we don't have numbers on the proximal surfaces. We only have a number for the occlusion. So for some reason, the software didn't see the neighboring teeth. So that's something we need to work on. The next thing that I see is it's not really aligned with the adjacent teeth. It's actually positioned more lingual. So what I would want to do is get this to align better with the adjacent teeth and also get this to see the proximal contacts. Those are a couple things that would be great. So this initial design is the software's AI. So this is the AI proposal. As I mentioned, some improvements need to be done. So what would I do first? So what we can do is go to, and we're going to first review modifying the AI proposal. If there's a large change you want to make, let's go to move, rotate, scale. So fourth icon down on the left, we're going to position this more ideally. So I'm going to grab, we want to move the whole thing to the buckle. So that would be in the middle. Each section has 3 controls. The circle's for rotation. The middle is to move the whole design. Let's shift this whole thing to the buckle. So something a little bit more like that. The next thing we want to do is, if there is a need for rotation, that's the circle on the inside. We know that the proximal contacts are open. We can expand those into place manually, but I'll show you a trick here. If the software does not recognize the contacts of the adjacent teeth, what we'll do is I went ahead and closed out of Move, Rotate, Scale. We're back in Contacts window. You can see the software does not know mesial distal contact. What we're going to do is on the bottom here, go to Edit Mesial, and we'll do that, follow this up with Edit Distal. So we're looking at the mesial contact, number 29. What we'll do is this section lets us draw where we want the contact area to be on the adjacent tooth. This is the same with tooth-borne restorations. We want to identify the contact on the area of the neighboring tooth that faces the restoration. So you can see this flat area. We can also see this nice reflection off that area. That's essentially where we want the contact area to be. Really important here, you're going to left click and hold and draw your contact, but don't draw it too large. So you're going to see I'm going to mark this a little bit smaller. If anything, that's a little bit too large. I'm going to draw it kind of like that. Software tends to over design it. So when we overdraw it, what can happen is the software might start hugging the adjacent tooth. One of the nice things about doing this, we're identifying the contact area, but you'll see once I hit the check mark, it will now see that contact. So now you can see we're 130 microns away from the neighboring tooth. Let's do the same thing on the distal. So we go to Edit Distal Spot. I like to look at it from the top. Let's see what part of the adjacent tooth is facing our restorative area. Because of the rotation of number 30, or rather 31, we can see we want the contact area to be a little bit more on this mesial lingual section. So this is really, when we're looking at this, this is hopefully it's getting into your mind that if you're not pre-adjusting those proximal contacts, if those surfaces are funny, it's a really good idea to be to do so. Usually we'll use just a fine grit diamond at a lower speed, just kind of shape that surface. If anything, we want it more flat, typically more convex in shape. But as teeth move on aged patients, natural teeth, when they're moving up against each other, they actually abrade and start to flatten those contacts. So younger patient has more convex shape. We so convex to more flatter, kind of like what we see here. We hopefully are not going to introduce a concavity into that surface, which is going to be really hard to adapt the contact and seat that restoration down. So this is kind of the contact area. You can see I'm just going to make a little narrow sliver here. Let's do something like that. Let's save this contact. And now you can see we're 60 microns away from those neighboring teeth. Now, the next thing that I'm going to do, we will hit the fixed contacts here in a second, but something that I like to evaluate is the relationship of the design with the opposing. How I mentioned this is part of that alignment with the adjacent teeth, establishing the proper occlusion. Look how funny this patient's bite is, edge to edge in the anterior and the posterior. We probably, some ortho would benefit this patient, but here, we're kind of stuck with where we are. So we've got edge to edge going on. We're going to try and create this similar edge to edge situation here. Not quite edge to edge, because edge to edge bites, we always really ideally try to avoid them. We want some type of overlap between the opposing, whether we want the cusp tips of the upper to be on the inside of the lower. You can see on number 31, he actually has a bit of crossbite on the mesial component, but on the distal, it's more close to the ideal, meaning the cusp tip here on the mid buckle, or rather the distal buckle, is closer, it's more lingual. So any type of overlap that we can establish in our bite is going to help things out. So what do I mean by that? Just to kind of elaborate a little bit more, we would want for the cusp tips to either be more lingual to the opposing or more buccal. And the benefit of that is reduced cheek biting, especially on the second or third molars if you're restoring back there. So I'm actually going to use freeform. I'm going to make freeform really large and just kind of seeing where we are. I would rather the forces with screw retained crown. Typically, lower mandibular teeth, we want for the buccal to be on the inside. So I'm going to favor that position instead of bringing them more buccal, which can result in more lateral forces. Again, we want to limit lateral forces on our implant. I'm going to move the occlusal contact, more lingual. So I'm just using freeform, just kind of tucking this in. I'm making sure they're more lingual to the opposing. So I'm looking at it from this occlusal view. We can check again with the opposing. Notice how we have this overlap. We can, of course, make the adjustment here as well, but I'm just tucking them more lingual. I'm not raising or lowering, just moving in a lingual direction. All right. Now that we're creating a better overlap, let's go back and see. Okay, so overlap. Now let's go ahead and adjust these. Actually, I'm skipping the steps. So we talked about broad contacts. Broad contacts, we can create it manually, or let's just go ahead and see what the software does using the contact refinement. We're going to start with the auto. So let's first talk about the value of these contacts. And if you paid attention to this latest update, we made some changes in the software. So I'm going to go quickly to tools in the upper right-hand corner and options. In this section for options, we have 3 tabs. On the left, we're going to go to design settings. In the design settings, the changes that we have made are to the default values for Bruxer materials. So Bruxer aesthetic, Bruxer now bridge, Bruxer now for the posterior zone. Let's first focus on those 3. What we set the contacts to are the original default for all materials was -230. So you'll see how -230 is still on the other materials, Biotemps, Camouflage, and Obsidian. For the Bruxer materials, what we did was we changed the default from -200 to -400 for the occlusion, and from 30, we went to 0. For the Bruxer now screw retain block, and actually just quickly on the change of the default, This was done for those. That number has changed if you were still on the original default of minus 230. If you modified those numbers along the way in your CAD journey to something that you found better, those numbers shouldn't have changed. So let us know if those did change, then you may want to modify that back to what you originally had. Now, minus 400, just quickly to close out this thought, minus 400 and 0, the change that we made to the default values, this is what we believe will reduce the amount of, assuming your bite scan was done well, meaning you didn't scan the bite with the patient slightly open. If the scans are done well, we think minus 400 and 0 will get you very close. But you may still need to calibrate this or adjust this to your specific needs. Minus 400 might still lead to a heavy contact in some cases. So if that's the case, maybe adjust up or down by 50 microns. So if minus 400 is still giving you heavy contacts, maybe the next time try minus 450. If 0 is still giving you heavy contacts, it's okay to go negative. Some folks are at minus 10, minus 20. Then you take it from 0 to a negative value. If minus 400 is too light for you, then and you want to establish maybe a little bit more closer occlusion, then you go to minus 350. So you may have to calibrate this to your needs. Now, moving on to the screw retained crown, this is what we have as our default. I'll have to double check what the original default is. I don't think it's these numbers, but minus 450 and 20 is what I have found to be pretty good for most cases. So what this means is for the occlusion, we're going from a tooth-borne to a implant crown. We're going an additional 50 microns out of occlusion. Part of that is due to the fact that implant crowns do not move, they don't compress. Natural teeth will compress a little bit. How much kind of depends on the patient and depends on the health of their periodontium. For the proximal contacts, you can see from 0, we're going to about 20 microns heavier contact. So try these out. If these are coming out too heavy, then you still have the freedom to adjust that however you'd like. So those are the default value changes that we've made to the software. Hopefully that leads to better experiences. But again, those numbers in the default will be preset when you open the case of that type, Bruxer, Bruxer Now, Bruxer Aesthetic, Bruxer Screw Retained Crown. These numbers automatically pop into the contacts window. If those numbers didn't work for you the first time or one of the early tries with that material, then here you still have the freedom to adjust up or down however you'd like. We'll probably have a separate video. I know contacts can be really maybe confusing to understand. Another area with screw retained crowns is the gingival position. You'll see there's this 0 here. So that's a good number for the soft tissue contact. It's very similar to bridge designs and for the ponic. Now, before I adjust the use fixed contacts, what I do want to pre-adjust, what I would recommend pre-adjusting if you plan on using the software's auto contact is look at the emergence profile of the entire restoration. So you can see we pre-contoured the tissue. I'm using freeform here. If there is a need to fill in spaces both on the distal, mesial, buccal, lingual, go ahead and use, I think freeform is a great tool to use for this. So you can see I'm just bringing this gingival contour down, and you can see I am creating a heavier contact. See, it's going to 400, and that's okay. The reason why I'm saying to pre-contour the tissue with freeform is because when we go to use the contacts window, it will zip away any areas that are heavy along that gingival contact. So here, this looks pretty good. I'm closing the space on the soft tissue. Let's look at the lingual. Maybe this is a little bit open. I like to have some, especially when we've pre-contoured the tissue the way that we did, unless it's really over contoured and you want to reduce that space, then of course you don't have to do this. But here I'm just pre-contouring. I like the diameter of the soft tissue space we've created, and this is pretty good. So pre-contouring is nice. We get the contours dialed in, and then the next thing we do when you are using fixed contacts, give that a click. It will close the proximal contacts, or rather adjust those contacts to what you selected using edit mesial, edit distal. It will reduce the occlusion, any heavy areas down. It maintains that buccal lingual position that we established, which is great. And then also, the final thing the software does is adjust the tissue area. I'm going to undo that quickly and just show you again what happens. We're going to hit fixed contacts. The order of operation, the software adjusts the proximal contacts, it adjusts the occlusion. The final thing is it's going to adjust this gingival tissue. So you can see it preserved a lot of that pre-contoured area that I made, but the areas that were too heavy, it smooths that down. It just reduces it. It zips it away. Now, the software is going to adjust the tissue to the shape of the tissue that was created. So because we had a really soft or smooth interface created by that custom abutment, when the software takes away material at the gingival portion, it's going to be done fairly well. If you recently, let's say you did contour the tissue with a laser or electrosurge, sometimes, and I'm sure you've seen this if you've done it, the tissue can be kind of bumpy or lumpy or irregular. It could be rough. If that surface of the tissue is not very smooth, the software will actually adjust those areas. It will pre-contour those areas to the bumpy nature of the tissue. If that is the case, what you might want to do, let's say it designed everything else well, the proximal contacts, the occlusion, the only area that distorted was the gingival tissue. What you might want to do is you can hit undo. Again, remember the undo if a distortion was created. Then back to the contacts window, you can deactivate the gingival portion. So see on this gingival section, I remove it, I turn it off, and then we can hit fix contacts again. Now the software will do everything else besides whatever distorted. And so the same applies to the other areas. Let's say a distortion occurred on the mesial or distal or just the occlusion because it started off really heavy. Then you will need to get that dialed in. Now, what this red is indicating, I believe it's indicating a minimum thickness situation. So, well, actually, no. I think the red is probably a little bit too low. Or too low, meaning below the height of the tie base. What you might need to do is, you can see how I move that up. It usually means it's warning you that the design is getting close to the tie base. It may be hard for the system to actually grind that away because of the proximity to the tie base. So you can try one of the tools to get rid of it and adjust that away. I have seen where, again, pre-adjusting the tissue, I had a little bit of a space, like a gap between the implant body and the soft tissue, almost like a retraction with a tooth, normal tooth prep. That vertical drop in the tissue, the software adapted the soft tissue into that space, and that whole extension became red. And then I wasn't able to mill it out. When I went to send to mill, it would give a warning. So that's just something to be aware of. If you see those red extensions underneath your design, that could be an issue. Now, look at the proximal contact. Something else new with the design is the software will reveal any areas of an undercut if there's a part of the design that is an undercut. So what that means is if we look from the occlusal here, notice how, and we're going to assume this is the perfect insertion direction identified by perfectly setting this hole from this occlusal view. That contact, what this means is the contact area is actually in an undercut. So because of the area around the contact being larger, what that means is it can lead to an accurate surface of the contact, meaning that contact area is probably going to be heavier than the 20 that you specified. So I'll show you what we can try to do. Hopefully this will be a little bit more automated and adjusted in the future, but what you essentially have to do is take away material around the contact, because let's say we want to preserve 20, we don't want to get rid of the contact to get rid of the undercut. So I'm going to concentrate the removal of material maybe on the top. I'm going to speed this up. Let's increase the strength here. See if this goes faster. And something that I did notice also is the smooth really, really kind of slows down. Let's try this. We're going to remove, see if we can speed up this adjustment. What I am essentially trying to do, I want to leave that contact area, but find a way to expose. And here it's just getting a little bit funny. So I'm going to smooth the whole thing now. I just made the whole thing heavy. Okay, so see how the contact area now is not, it's red for a different reason for being too heavy, but it means it's no longer within the undercut. This is ideally what you want to see for your contact area. You want to see the contact normal without red in the contact as we see here. So let's try this again. This is what I mean from earlier about opening that occlusal embrasure. So I like to have a little bit of a space. See, I removed the undercut up here. Let's see if we can see this again. I'm going to undo and bring that back. So you can see the undercut formation by smoothing away material that is essentially hiding that contact in an undercut, we can establish the contact there. So this is something that is really important. So making sure the contact is not in an undercut and also not in an undercut of the adjacent teeth. You can see the undercut here. If part of this design was inside of there, you're going to have a tough time seating this restoration. So I apologize. I know we're kind of getting up on time. So let me move back to the slides here and let's finish looking at the finishing of the Bruxer screw retained crown. Like your tooth-borne crowns, the software and the mill does thin the sprue connection. We separate the crown from the mandrel or the piece that is held in the block or in the mill, excuse me, using a fine grit diamond or whatever your preferred finisher is. Finish down the sprue. There I was using a fine grit high-speed diamond. We're seating the crown into position. Of course, checking the contacts. I like to go ahead and pre-check the contacts before we even tighten things down because sometimes once you tighten it, that can also change. So also check after you've tightened it too. But I'd go ahead and do a pre-adjustment first, making sure it seats into the implant passively. Here I'm using the brown polishing wheel from the Bruxer polishing kit, or you can use whatever preferred polisher that you like. If you are polishing, making sure the polishing compound does not stay, so it's a good idea to clean the restoration surface. Even if you're not polishing, cleaning the restoration just to remove some of the coolant fluid from the mill is also really important. Now we're just going to tighten this restoration down. So for our Han implant or Glidewell HT, we're tightening down to 35 Newton centimeters, tightening that down. Good idea to recheck the contacts. And that is the Bruxer screw retained crown in position. Now, as I'm speaking through this, there's one more thing that I wanted to mention on the design. It was lowering the contact surfaces. So this is 50 microns, a little bit lower than I would typically have my tooth-borne crowns. I'm looking at the contact or cusp heights of the adjacent, or excuse me, the non-functional cusps and comparing to the adjacent teeth, making sure that those are a little bit lower. What we really, and this is partly why I don't like having the full arch scanned in, when we activate the opposing, there's more things getting in the way. So evaluate the non-functional areas. We really want to limit the height of these non-functional cusps. What you can do is, of course, use freeform to drop those. And you can also smooth these down. Just kind of run your smooth surface. I like to just remove the sharpness of those cusps to catch potentially when the patient moves into lateral excursions. A request has been made for dynamic occlusion, being able to see, check for lateral interferences, but this is something that you can do preemptively just to make sure those are blended in a little bit better. So again, one of the other additional measures we can take to reduce the amount of lateral forces on these implants. All right, let's see what else we have here. That is the radiograph of our completed restoration. Just really quick on access closure, you may all have your preferred option. What we use, or really what I use, PTFE. It's been studied and really recommended as the most favorable material. It really reduces plaque adherence. Um, the worst material is cotton. So cotton roll, cotton pellets, really don't want to use that. That is the worst material. There's other options out there, but PTFE really inexpensive and works really well. Depending on the height of, the amount of PTFE really depends on the depth of the implant. Really low implants, you got a longer channel and space to fill in. One of the benefits of screw retained crowns is retrievability. So if you ever have to get back in there, I want the PTFE within 2 millimeters of the occlusal portion of the occlusal surface, occlusal table. So if the first amount of PTFE, it really gets buried in deep, we're going to add more PTFE. I want to, and then also make sure they're tightly packed down, really sturdy to help stabilize the composite that we add on top of it. If it's kind of squishy and movement, it could lead to really debonding of that occlusal composite plug. So pack down tight. I like to go within 2 millimeters of the occlusal table so that if we have to re-access that area, I'm not having to drill down. I've had to cut through other implant restorations where there's a lot of composite down to, and that's pretty anxiety inducing. So I don't like that. Once the PTFE is packed down well, we rinse the site, make sure it's nice and clean. You can use zirconia cleaners to kind of clean that access, but I really just make sure it's really nice and clean. There's no contamination, blood, saliva, it's clean. Um, Another thing, just another note on the PTFE, making sure that the PTFE is not against the vertical walls, making sure really you get the PTFE down. And I want that level. I want exposed zirconia for the composite and bonding agent to come into contact with. So I'm using a universal bonding agent. We're typically using Scotch-Brite Universal. Whatever your preferred bonding agent should work well. Ideally, something that is universal that contains MDP with a little bit more chemical adhesion to zirconia. Air thin, and we go ahead and cure that composite, and then I've got my flowable composite ready to go. We're going to flow that in. Usually I'm going to flow about 1 millimeter since I'm about 2 millimeters of space, 1 millimeter layer first because factoring in the shrinkage will cure that, and then another layer to help seal it up. There's a chance if you just overfill, or maybe you're using a bulk fill composite, whatever you like using works great. I like flowable, just makes it nice and easy and adapts well to the site. Sometimes I'll use an Explorer and just kind of agitate it and adapt it to the area for better adherence. And I'm sorry, I know we're a little bit over time, but I do want to quickly cover this case because there was a complication that I encountered here. So this patient, we had an extraction at site 18. That is a bruxer crown on 17. We have our Han 5.0 implant again. It's kind of our standard size in the posterior. There are larger implants coming out. There is a 7, soon to be 6 as well. But this is the scan body in position. We make the screw retained crown. And I'm going to actually quickly, let's open this up. So screw retained crown is in position. And this was in service for 3 months. And this is a look from the buccal. Really nice emergence profile. But in 3 months, this happened. So failure, like actual complete failure of the material around the tie base. What happened? So this is the design. I'm opening the design now. Let's see here. This is the initial proposal. You can see still a little bit of an open contact. We won't go through the whole thing right now, but really what happened was we had this site closed with a stock healing abutment. All right, so stock healing abutment makes the stock healing abutment, the base of that stock healing abutment is the same diameter as the implant, meaning it's about 5 millimeters. So the channel is 5 millimeters wide from the implant up to the tissue level. And then at the tissue level, you can see the restoration designs out like a mushroom to close that restorative space. This is what it looks like afterwards. See, we have a real narrow, almost 5 millimeter channel. And what that is or creates is a real thin area of zirconia, because keep in mind, we have our prep on the inside of this, which is the tie base. So we have a minimal thickness situation leading to a really high cantilever design up top. And that is the result. This is what happens this is actually a library design, and using the software's fixed contacts, we showed you how the gingival contact is adjusted last. So proximal contacts get done. And this is what happens. Again, the software is going to adapt the gingival portion, the gingival, to whatever the soft tissue is. And what we're doing is we're creating a really unfavorable situation with a really thin zirconia channel. So what do we do here? So what I did, or rather, let's take a look again at the designs within the block. So in the middle is the anatomy of the block. We have kind of a small, this is about 3 millimeters tall of a titanium abutment, and a lot of the zirconia material, which allows for really a multitude of different designs. But the first design that we had was a situation where the implant was not placed very deep. It was rather shallow and pretty close in height. The ideal situation is the implant level is close to the CEJ of the other teeth. And so we have a favorable condition, like the implant abutment to restorative design ratio is pretty favorable. The second case here, because of the implant being placed deeper, that lowers the titanium abutment down into the ridge. And now we have a large portion of zirconia above that. Well, pretty much the whole coronal portion of that restoration is above the really thin area created by that narrow channel. Okay. So what we did what I did was I opened up the tissue. So I used our water laser and basically created better space, essentially a bowl, kind of like what we had with our custom abutment. And this is why I really recommend either custom abutment, or if you're doing a second stage, or if you're using even a stock abutment, stock healing abutment, or cover screw, some method of shaping that tissue, whether it's a round burr, whether it's a soft tissue burr, whether it's electrosurge or something to open that space is really recommended, because not only will you create better emergence profile for your design, but you're thickening up the area around that tie base, around your prep, for optimal strength. So that way, when lateral forces do get applied, lateral vertical forces, downward forces get applied to that restoration, there's a little bit more bulk of material to help support those forces. So really very important. This is a buccal view of the space created. And again, hopefully it's done pretty smooth, but if not perfectly smooth, you don't have to necessarily use the soft tissues, just fixed contacts. You can manually adjust it. This is not the same day of our scan. What I'm showing here is after the new design was in position. After the new design was in position, we had the crown in. We removed it after a couple weeks to show the nice way the soft tissue heals. This is the new restoration with the access channel filled in. Same buccal appearance, but below the gum line, or rather subgingivally, we have more space to help support this large coronal portion. So this is what I mean. Screw retained crowns or just implant restorations, it's not ideal. You know, the ideal situation is we have a foundation that is nice and wide. The implant body is nice and wide, but where we're at in dentistry now are these tapered implants, and we have a lot of good evidence to support it. But even if the implant position, direction, everything's done well, we still have to create favorable conditions for optimal strength. I want to show you here radiographically. Left-hand side was the original design. Right-hand side is now the new design. I'm happy to report we're now over a year into it, but I still think we can, there's some things we can do to improve the anatomy of this situation of the implants. I've seen lab-made screw retained crowns also fail, probably from these thin channels that are created to, it's all about, I mean, it's just general physics, will a really thin bonded zirconia interface. We essentially have on the left-hand side here, really thin veneer zirconia bonded to that tie base. And then now we're putting all of these crazy forces cantilevered forces, lateral forces on the restoration. Could I have improved the situation by maybe reducing the heights of the cuss tips? Probably. Going back and looking at my design, my original design did have some, you know, if we go back here, the cuss tips were kind of high. Let's see here, maybe kind of high. Those lingual cusps probably could have been down a little bit, but one of the best things to do is just to make enough space for the final. So I'll make a separate video on the design of this case because I want to respect your time. I know we're kind of at the end here, but I'll just put my information up here. If you guys have questions after today's presentation, feel free to reach out to me, emails on the left. I'm going to check back in with Helen or Leah, or Helen and Leah, see if there are any questions that I can help answer before we wrap up today's session.
Hey, Dr. Chi. So we have a few questions here. First
Okay.
question is, any plans for allowing for anterior restorations?
At the moment, no, because of how difficult it is. Anteriors, oftentimes, just getting the screw channel in the right position, it's not very easy to do. A lot of anteriors that we see in our practice, we try and make screw retained crowns when at all possible. It's when we have ideal conditions, but anteriors we end up with unfortunately unfavorable angulations. So at the moment, not at the moment. What we are focused on is expanding on the posterior options, compatibility, being able to expand to other systems. And what we're also, and this is our big hope, is other materials beyond just the Bruxer now posterior option. What we'd really like to see is like either a camouflage or a biotemp. Those would be more favorable for provisionalizing custom abutments. So I think we could get a lot of good use out of those.
Next question is, the iTero Lumina will allow multiple bite options for restorative cases, such as protrusive, right and left, lateral intrusive, and centric, starting next week. Will we see excursive movements in fast mill/fast design to design our screw retained Bruxer crowns or traditional Bruxer crown?
Great question. Unfortunately, not right now. And this may change soon. I hope that we can register it. Right now, we are really just looking at that singular centric or MIP bite. And I would love to incorporate that dynamic occlusion. Other scanners also have that option. Medit has lateral movements and lateral intrusive, protrusive. Um, we would like to incorporate that. And I'm really just telling the software guys, like, we could take the records provided by the scanners, but really what we need, because we have fixed positions, right? Teeth, if we are able to just figure out teeth sliding against each other without invading that space, lateral movements, protrusive, even if it doesn't line up perfectly, we at least have tooth limits in all of those directions. We just need to get our software to be able to do that. And then we can already begin to see, because when we go side to side, let's say when we just take the models and go side to side, we are using the unprepped teeth or the non-restored or non-restoring tooth or teeth to see the guidance off of those and whether or not we run into lateral interferences or protrusive interferences with that. That is simplifying it, but I think that is really the key thing we would need. So, in short, not yet, but hopefully soon.
Next question is, how do you get the custom healing abutments?
How do you get the custom healing abutments? If the best or really the easiest way is if you are treatment planning the surgical procedure with us, you can request it during when you ask for the digital treatment planning, and then you'll get the healing abutment back with the surgical guide. If you are just wanting a custom healing abutment, you can also do so after the implant's placed. You would take the traditional impression, ask for a healing abutment. That process is maybe less than ideal because in between, there's definitely time to or for the tissue to collapse into that position. You can also do it after second stage. If you after everything's nice and healed, you open the implant, re-access the implant, take your impression. That's another workflow, potential workflow, but the custom healing abutment might be done larger than what you've created, and then you've got to maybe re-surgery the site, recontour the site during the placement of the healing abutment. So the best thing really I see is to get that done during the planning phase. When I first started placing implants, I did learn freehand because it really is important to know. But now I'm almost 100% freehand, 100% guided, because guided just makes it so much more predictable and things just kind of line up better. And we have an opportunity, if you are using guided in the future, to pre-make provisionals based off of it. Actually, we do that now in the lab. Everything is provided for you. You can choose the custom abutment after the guide to be placed, or the maybe in the anterior zone or a lower functional area, typically anteriors, to have implant place with the surgical guide. We know exactly where that implant goes. We know exactly how to put the biotemp provisional into position. So we have an opportunity to do the same thing that the lab offers chairside through a guided workflow.
Can we stain and glaze this block?
Can you stain and glaze this block? You can't. Technically, yes, but why do I say you can't? Because the and this is the same for screw retained blocks in the lab. So lab-made screw retained crowns, those are stain and glaze. So you might be wondering, why does the lab do it? The lab will stain and glaze the crowns before they bond the crown to the tie base. So the tie base bond, or the crown being bonded to the tie base, is done last. Because these have been bonded beforehand and we mill it in its final state, if you put that into the oven, then it's actually resin cement at the interface. So when it goes into the oven cycle, it's too high for the resin to really survive that. And so the resin interface basically burns out. So and I say technically you can. So let's say you put this in the oven with all your nice stain and glaze on there, you can fully expect for the tie base to just easily pull out. So what happens if you did that? Let's say you really wanted to stain and glaze, you can go through that, but you have to reattach the tie base. But hopefully you're reattaching it in that same orientation, which, there's a little bit of rotation, really tight tolerances, but getting it back together, you may not, either the rotation or even the depth of the implant to or crown to the tie base could change. So just be aware of that if you are really wanting to stain and glaze. If you're really wanting to stain and glaze the situation, or a chairside milled crown, you may be better off just getting a custom abutment made, and then, you know, um, going through making a normal crown to fit to that custom abutment that affords you the opportunity to stain and glaze and without screwing up that bonded interface.
All right, and last question. Are biotemp and camouflage screw retain being actively worked on?
Right now, it is in the planning phase. So planning just means it's on a roadmap. So actively being worked on, not quite yet. So we are really pushing for that. There's so many projects and features and updates that the hurricane that is Glidewell is working on, and we hope for that to be a near-term option. So stay tuned for it. I'm going to keep pushing for it because um, that would be a really nice addition to this workflow. So I know we're just seeing, hey, let's make some final restorations with Bruxer screw retain crowns, which is fantastic. But how are you provisionalizing, or how are you, um, let's say you're placing the implant, how are you letting that area heal? Having a biotemp option would be fantastic. What you can do now, what you can do now is, let's say you are placing the implant, or let's say you're just restoring, either way. So you could place a stock abutment, temp cylinder, stock abutment in position, scan it in, treat it like a prep, It's a little bit of a workaround. It's not ideal, but you can treat that as a normal prep, mill out your biotemp or camouflage as a healing abutment shape or provisional that is out of occlusion, or if the site has already the implant has already integrated and healed, and all you really want for that biotemp to do is to pre-contour the tissue. If you're in an aesthetic zone or even in the posterior, you could just create the optimal contours, optimal shape, bond that to the temp cylinder or tie base. You can even convert that to a screw retained crown. It's a little bit more work. You obviously have to create your screw access channel, bond it to the base, and then you have room to pass the screw through, and you essentially now made your screw retain provisional with camouflage or bow temp. Or you can make a permanent camouflage if that is your preferred final restoration. So I know it's a little bit more work to do, but that option exists now. It's a little bit of a workaround, but you're just, instead of defining it as a screw retained crown, you would just define it as a normal crown to a tooth, set the tooth number, but there will be a little bit of post-mill adjustments you would make. But now you're just adapting to marking the margin on your stock abutment or temp cylinder, and then contouring in design to that ideal shape that you want. But what you to make that workflow a little bit easier, at least on the scanning phase, is fill in that screw access channel so that material won't build into that space. Good question. Thank you for the questions.
All right.
Anything else?
That's all we have for today, Dr. Chi. So
All
you
right.
will be receiving the link to this recording after about 2 hours after this webinar ends. Thank you so much for joining us, and hopefully we'll see you all at the next office hours.
Thank you all. Have a great weekend. See you guys hopefully soon. Take care.